Yes, Suresh, floor is yours.
Okay. Good evening, everyone. Thanks very much, Professor Shubhankar Chowdhury, and it's nice to be a speaker under him. Thank you for the opportunity, and it is the previous speaker made my job much easier. I think she was quoting almost 6 or 7 times that how the next speaker is going to be coming up with the real facts. So the intermittent fasting is clearly superior. It's not the way that it is going to be the small frequent meals. So before even talking about the science, I want to just tell you there is 2, 3 things actually. The pragmatic or the practical way how you're going to deal with this kind of diet. For me, there is 3 things, 3 C's, for example. One is the compliance, whether it's going to be long lasting, the answer would be no. And whether it produces confusion for the person about the methods of intermittent fasting, answer is possibly yes. And whether there is a confusion for the patient himself after getting into a fasting state and getting into a confusion and irritability. My previous speaker was saying that confusion and the irritability and everything gets much better over the time, but it's like marriage. I think sometimes it may not be you're saying that you have to try to live and it might get better, but that's a hope. So I'll tell you some signs, and I think if you look at the small frequent meals, the increase in frequency makes the lean body mass, and we got evidence to show LDL is decreased, and then it got almost like an incretin effect with delaying gastric emptying, and that causes almost the fullness actually. So if you have a multiple frequent meals, the cholecystokinin and all the gut hormones comes into play, and this has been happening for many years. I think the quoting was a small island from Japan, but if you look at the world-wide Europeans and the people who live in Mediterranean, they are used to habits like a small frequent meal. And we know that the thermic effects of the food, which is like diet-induced thermogenesis, that is almost 60% based on metabolic, 30% activity, and the TEF for each macronutrients is there, but I think the energy takes it to metabolize the food and the heat is produced, but eat a decent amount of food. But I think TEF, what happens is it increases the metabolism and results in the needed to the digestion of food consumed. So the key is very small meals with a strong consideration of macronutrients is the way forward. What is the evidence for it? These are all the pooled data of the RCTs over the years from 2012 to until now. And you can see the, I won't go into the details of each and every study, but the BMI, the lean body mass, and the total body fat all comes down with amount of frequency of meals. So you can see here where the frequency goes from almost 6, the head-to-head data showed the multiple frequency meal is the one which produces the BMI reduction, lean body mass formation, and also the fat mass decreasing. So this is like a pooled observational studies over the years from 1960. So you can see again the multiple frequent meals is the one that produces almost like a negative correlation between eating frequency and body weight. So if you eat more frequently, the body weight observed in male, of course you have to look at the calories what you eat, but I think it is inversely proportional, and if you adjust to the sex and the physical activity and everything, still there is a lower risk of developing obesity in those people who are eating more frequently. So hope you understand with the studies of RCTs I've showed you and also the observational studies, it is clearly evident that not only the BMI, lean body mass, but the weight and also other metabolic parameters increase significantly. So this is one of the data my colleague has shown as well, but I think if you see from 1994 and 1989, this page, this slide shows 1 meal per day data, and that is showing in the right-hand side with CHD risk parameters. There is not much of significant benefit. So if you go to the next slide, which is 6 meals per day, which shows significant benefit in the total cholesterol and also the bad cholesterol like LDL, and then there's some improvement in HDL as well, which is a real bonus when you do get it. And this is published in Circulation in 2017. So again, just to show when you go for a more frequent, like a 9 meals per day, there is the benefit is still there. So the summary is, when you have one meal, the cardiovascular and CHD risk parameters are not that beneficial. But if you go for a 6 or 9 frequent meals, counting your calories, then there should be a benefit with the CHD parameters. So this is the thing. In the second or third slide of my colleague shown, there are quite a lot of different types of intermittent fasting. And I think the definition itself is not clear. We are talking about a wide area of different types of fasting. Time restricted, once a week, alternate days, and you're showing a data for one thing, and then you wanting the people to understand that the intermittent fasting is the new sort of gospel sort of thing, and it is not true actually. So it is very, very confusing, and there is energy restriction and twice a week. I mean, what is that? I think people get confused. So people might think, I think it might be just between the meals, you know. So this is another data my colleague has shown with the 19 studies with the meta-analysis data. So she showed the benefits of the body weight compared to the baseline, but there is only one study which showed the significant overall positive effects. And how can we consider this is a beneficial effect in this meta-analysis? It is not at all beneficial. I think she showed this data in a nutrients study of 2020, but it shows how can we consider this is a beneficial effect when there is heterogeneity, which is slightly in the higher side. So this is the paramount importance, leave alone the fact that what is there as a definition and what is the confusion about the definition and what is the evidence which is there. But the safety of the intermittent fasting, now that energy restricted period, definitely they don't feel good, and non-energy restricted period also not feeling good. It is a full lockdown or a partial lockdown in COVID, you know, there is no feeling good factor there. So feeling cold, tiredness, she mentioned about the irritability, but the lack of concentration is definitely there. I mean, you and me know when we are hungry and everything, how irritable we can be. Leave alone that the long-lasting fasting, people just feeling cold, tiredness, excess loss of energy, and then dizziness will comes in, cramps in the leg, you name it. So there are quite a lot of troublesome things. So no one select the troublesome option, definitely not. And if you do that, I think you have to explain every time that that you are in hunger, and you have to just carry a board of some sort that you are in intermittent fasting, because the lifestyle might get changed and your daily life can get affected, your relationship can get affected, there might be multiple thoughts. Leave alone all that, but if in a diabetic, what a big mistake if you're going on that. It's just the hypoglycemia risk is so high, and also during the fasting days, in individual, if you don't reduce the medicine, then there is a big challenge. But if you do the reduction of medicine on fasting days, if there is a less than 400 calories, then the possible hypoglycemic mechanism. So firstly, I mentioned about 3 C's. One of them is the compliance. So anything what you start in life, I can see in, at least in the region where I live in, a new diet started, and then even almost restaurants were opened, but I think it was not almost it was given away because people are not following it. So the compliance, so whatever we follow at certain age or following as a procedure or a lifestyle, it has to be compliant. And I think intermittent fasting cannot be sustained, and it's almost like 20%. So what about non-fasting days? So you're saying the non-fasting says super good, but I think it works by creating a calorie deficit, though the periods of fasting than few. So people will be feeling awful even the non-fasting days, but it will be only be successful if you eat relatively normally on non-fasting days. You can't eat too much on that. So effectiveness of intermittent fasting and time restricted feeding compared to the continuous energy restriction. So if you do a continuous energy restriction, is it much better compared to a time restricted thing? If you look at it, the last area, it shows that overall available suggest that both intermittent and also the continuous one, out of the 9 out of the study shows no difference between these two groups. So you don't need to be doing an intermittent fasting. So it just cannot be assumed as a weight loss program, but as a detox or a regeneration or something like that, and longevity extended process. So we think that intermittent fasting is a new diet trend. No, I think our lifestyle, a lot of people are like this. We are doing it, but that doesn't mean they are getting benefit out of it. So the latest and largest RCT, my colleague was mentioned, to determine the effect of 16 and 8-hour time restricted eating on weight loss and metabolic markers, and there is no there was a significant decrease in weight with the intermittent fasting area, but I think there is no significant changes in the secondary outcomes between these groups. So skipping a meal is harmful, definitely, compared with the man who eat 3 meals a day, ate 1-2 times a day, that there is hazard ratio for diabetes mellitus is 1.26 after adjustment, and also that is even if you try to alter for BMI, but there is in contrast, if you eat frequently, the diabetes risk is less. So this itself says it is harmful, don't go there. So big picture is big no to intermittent fasting. So unless you got other reasons, like if you forget your groceries, for example, you can tell your family that you go around fasting, and there are other reasons to become fasting. So just to summarize, increasing meal frequency appears to be an excellent method where there is delaying gastric emptying, decreased satiety, works like an incretin, and also there is much more to it. It is just a cardiovascular profile, improves particularly the LDL cholesterol, total cholesterol, and insulin. By restricting calories, it doesn't provide an extra health benefit at all. And I've showed you about the diabetes and also other benefits. And if you look at Asians and Indians, for example, we eat a lot of spicy food. And if you're starving yourself, you really get into trouble. Most of us already had GI symptoms, but I think the fasting in an Asian could be disaster with other health benefits as well. And difficult to follow, and it can't be sustainable. It's not sustainable with many adverse effects. So my conclusion is, I think small frequent meal is much better alternative than the restricted one. If you are looking for immediate benefits, probably short time you can do, but it can't be much beneficial in the long time. And if you make our patients starve or give us a prescription, they won't like you after some time. They'll try to find probably a different doctor. And anyway, just to summarize, this is eat a small frequent meals and also combine with a low glycemic food. Aim to have a half plate of vegetables, take a short walk, and these are all the recipes. Thank you for that.
Thank you, Suresh. I think the main planks of his arguments were, one, that compliance could be an issue with intermittent fasting, and two, it may be associated with better weight maintenance or weight loss, but eventually what also matters is cardiovascular risk factors. So of course, we didn't talk of cardiovascular events, we didn't go up to that, but at least the risk factors possibly are not so favorably influenced. So a couple of minutes to Beatrice for her rebuttal.
Yes, we have presented actually both sides of the picture, like for both the types of dieting. But whatever the diet is, what makes the diet successful is the adherence to the diet. So how feasible or how practically possible is it for somebody to have small, frequent meals? So we live in a fast world, and my opponent himself, being a busy practitioner, I'm sure is missing 1 or 2 meals a day. So, and there's enough evidence to
no. Top priority is eating.
There's enough evidence to show that, small frequent meals may not be sustainable, and in fact may lead to overeating in the process. And the studies that have been quoted by my opponent, they are not long-term studies. And many of the studies were done in controlled settings. And these cannot be extrapolated to real life settings, where some of the studies, in fact, have been done in real life settings. And the limitations of the study were exactly the problem that we face with small frequent meals. That is, the patients either underreport or overreport their calorie intake. So we have enough scientific evidence to show that intermittent fasting acts on metabolic risk factors.
Right. Thank you. So we will now have opinion, final comments, the neutral voice of Professor Nilanjan Sengupta.
You have to unmute, sir. Professor, you have to unmute again. Yeah, now.
Yeah, I think the host has unmuted me. Am I audible?
You are.
Let me share my screen. I have a small presentation.
And while Nilanjan gets ready with his presentation, let me just share that the reason I took or wanted this topic to be discussed basically is for me to learn from it. Because there is so much of hype about intermittent fasting. I hope Nilanjan will finally let me know what I should follow for my patients.
Thank you, sir, for giving me this challenge of being the neutral voice to the excellent debate by Suresh and Beatrice. Well, to me, time-restricted eating or intermittent fasting, whatever you call, is now a novel nutritional concept, and which has been aptly defined by Beatrice. But having said that, in some form, this is practiced by many ascetics. Beatrice has taken us to a Japanese island, but I think we can just go to the Himalayas, and we have the Himalayan ascetics who practice it, who have been practicing it for years, for ages, centuries, and is also common in the animal kingdom, and is maybe a part of any healthy eating program. What Suresh has said, by intermittent fasting, we are actually clubbing many things. The definitions are not uniform, so we cannot extrapolate data with one others. And these are the host of benefits at the cellular and molecular and also the clinical level, both in rodent studies, in the Drosophila and in human beings, that has been aptly summarized by Beatrice to buttress her points. I do not disagree them on a basic fundamental ground, on a basic fundamental platform. But then there are disadvantages which Suresh has pointed out. First, the lack of uniform protocol, which I've alluded to. Whether this intermittent fasting is physiological or not can be debated, but it is definitely something outlandish to the present day free living humans. Why? A reason why this should be met with a 20% compliance. I think 20% compliance is also something more in the long term. And it is therefore not sustainable in the long run. Then the risk of hypoglycemia would be there in patients of diabetes who are on pharmacotherapy, and that may necessitate some changes in the antidiabetic therapy on the fasting days if alternate day fasting is followed, which would be very disturbing. We know what happens to patients who are on hemodialysis. They land into hypoglycemia. Definitely that would be unsuitable in pregnant ladies and with certain comorbidities, as for example, with chronic duodenal ulcer. Hunger pangs are definitely not something desirable, and excessive satiety on feeding days also can be equally discomforting. And as Suresh has pointed out, in 9 out of 11 studies, there was equivalent weight loss with intermittent fasting as compared to chronic energy restriction. So we are taking so much pains, and the end result is an equivalent weight loss, not a superior weight loss. Of course, Beatrice has quoted one study which have shown greater improvement in insulin sensitivity, better lipid profile, and better, more favorable cytokine profile with intermittent fasting. That would be a food for thought. But again, another study have not failed to show any superior weight loss with alternate day fasting as compared to the standard conventional calorie restricted diet. Now, by standard conventional calorie restricted diet, I do not imply 6 to 9 meals a day, which Suresh has pointed out. I would be happy with a standard in a non-pregnant adult with a standard 3-meal, 2-snack pattern that we are following. So my take home is that ideal animal, including human diet, should be one which consists of optimal energy consumption, which may translate to chronic energy restriction to many humans with some amount of time restricted diet. Because if we are actually not allowing the patient to take any meal after supper to breakfast, that is in some form of a time restricted diet. In cardiometabolic practice, therefore, it is the chronic energy restriction, a rational one, is to be encouraged as a therapeutic approach at the present moment over this TRE or time restricted energy intake till we get even more data with clinical researches. Not, I mean to say, not with animal studies, but further clinical researches are needed. But time-restricted eating or time-restricted feeding superimposed on chronic energy restriction may be advised, may be considered in consultation with certain subjects in certain selected clinical scenarios, which also Suresh has pointed out, in otherwise very motivated, healthy individuals, not at extremes of age, who are motivated for long-term adherence and who are not vulnerable to hypoglycemia. I would thank both Suresh and Beatrice for dealing with the topic in an excellent fashion. And I end with this koala, who you know is one of the best examples of following time-restricted feeding, because the koala sleeps 20 hours a day, wakes up for 4 hours at night to eat some eucalyptus leaves, and they have a lifespan of around 14 to 15 years, which can be equated to around 90 to 100 years to a human being. Thank you. Over to Sir.
Thank you, Nilanjan. So I thought during your presentation, you were heavily in favor of Suresh, maybe because he holds an important position in Endocrine Society. He's the vice president, maybe because of that. But finally, you said that the koala will, like the koala, if you follow a time-restricted eating, then you live 90 years and hopefully productive, healthy, like 90 years. So what do we get from it? I mean, you are being politically correct?
I managed to confuse our audience.
Right. It should be a healthy koala, sir. It can't be pregnant koala, or it can't be any other koala.
Yes. Yes. So as I said, I am still a little bit confused, but and trying to sort of form my own opinion as well.
So this is a successful debate.
This is a successful debate. This is a successful debate. So what I personally feel, if you've got diabetes, especially if you're on hypoglycemic agents, following a time-restricted feeding pattern could be much more challenging. It's not that you cannot overcome the challenges, but you can, but it's much more difficult. But in those who are not yet diabetes or not yet on hypoglycemic agents, possibly time restricted feeding pattern could be implemented and hopefully will have its advantages. Now we have a few questions in our chat box. So Dr. Jain, so Dr. Tripathi, we go to Dr. Ahuja. Yeah, very important question. So there are so many diet plans: DASH diet, Mediterranean diet, vegan diet, Atkins diet, so on and so forth. Do we need fasting additionally to these diet patterns? So would Beatrice, Mediterranean diets, wonderful diet. So do you also need to fast?
Sir, I will just combine what Dr. Nilanjan had told us. So it's continuous restriction, that is restriction of food combined with following the circadian rhythm is what should be followed. So it should be a combination of both. It's not like the time that you're eating, you go and binge on everything. So you follow a healthy pattern, and at the same time, you also respect the circadian rhythm so that there is no desynchronization as such. And I feel the most important factor in any diet to be successful is patient's acceptance and compliance and long-term adherence.
Right, and that takes us back to both Dr. Suresh and Dr. Nilanjan, who did point out that when we talk of intermittent fasting, it's not just intermittent fasting on a diurnal basis. What you said, what's commonly touted is also maybe 2 days in a week or something like that. So how does that correlate with the diurnal rhythm, the biological clock? If you're fasting maybe 2 days in a week, how does it matter? The biological clock will run its own way, even on the days that you fast totally.
Yes, so that may not be totally in relation to the biological clock. Here it is more of the calorie intake. So what the studies have shown that even on the days that they eat, people are not able to make up for the calorie loss which is happening on the fasting days. So that is the concept of the 5:2, which is probably more acceptable to a fewer patients.
Right. And Dr. Riaz, a very pertinent question. I think calorie restriction is more important for weight reduction. Whatever way you can achieve it, it is true. But at the same time, I must say that there is something called chronobiology. Your mitochondria are active at certain parts of the day. For example, maybe the uncoupling protein. So if you tie that to the time of food intake, I think even on an equal calorie diet, taking it differently, maybe at certain times of the day only, could give you better advantages, even in terms of weight loss. It is what my reading of this topic has been. Anyone wants to rejoin into that, add something?
So may I say? Yeah.
Yes.
Yeah. Actually, I was going through the literature in animal studies or also in some human studies. That is the basic premise of many of the intermittent fasting regimen derived studies. But then we need to have larger studies to say whether that translates into real clinical benefit. And as you have rightly pointed out, intermittent fasting on a diurnal basis can be justified on the chronobiology more than on a total fasting for 2 days of a week and eating on the rest 5 days. To me, that appears less scientific. If at all we have to go for some sort of intermittent fasting, that should be on a diurnal basis, maybe which we are in any way following. Maybe we can increase the time period of fasting.
And that takes us back to your Himalayan, the ascetics, the sages. And however, at the same time, if you look at the Ramadan time, that's also a form of time-restricted eating, intermittent fasting. However, various studies have shown at the end of Ramadan, actually people do not lose weight. They
at all.
tend to
They-
gain
They tend to gain weight.
somewhat.
They gain weight.
They tend to gain
So
weight.
still remains a complicated issue, and we will wind up soon. And so since I can still see Sanjay Varada there, though he switched off his video, and Dr. Pramila Kalra. So you are also welcome to join and add to the knowledge base. So Dr. Riaz.
Pramila is in my team, sir. So
Sorry?
Pramila is in my team. So I spoke to her already.
What team? What team? We are all on a learning process.
No, I'm just joking. It's supposed to be.
I don't know whether you may have paid her something or whatever.
Yeah.
Right. So Dr. Riaz would want to know what many people eventually will not be able to lose weight. So when do you advise? Oh no, this is from Dr. Agarwal. When do you advise bariatric surgery? Would Dr. Pramila want to answer if she's still around?
Yes, I'm there, sir. So bariatric surgery, what we have to first understand is,
so your Ramaya Hospital does a fair bit of bariatrics.
Yeah, we do sir, bariatric surgeries.
Right.
But we also have to understand that we cannot just offer it for everyone. So first of all, obviously there are lots of, now even if we talk about diabetes and obesity, we know that there are so many drugs we have like SGLT2 inhibitors and GLP-1 analogs, which we have seen very good benefits in our diabetic patients as regards to the weight loss if we talk about. And also, like, obviously I agree with both points of view. We have benefits of intermittent fasting also, because we have patients whom we have put on intermittent fasting.
Now we have a direct question from Dr. Agarwal. What is the right time to refer patients for bariatric surgery?
So bariatric surgery is like when the patient has not been able to, patient is morbidly obese, then the point of time comes when we offer the patient to go for bariatric surgery. So bariatric surgery is like, what we are talking at the moment is the benefit of various diet versus drugs in diabetes. But over a period of time, if we have a patient who is diabetic, who is morbidly obese, then we can refer for bariatric surgery. And then we have multiple benefits, but we have multiple issues also after bariatric surgery. It's not so simple that we just refer a patient for bariatric surgery, because now we also have few patients who are coming with post-bariatric surgery complications. So it's like we have to see the balance, and then we have to decide which type of surgery we are offering for, like sleeve gastrectomy versus Roux-en-Y and all these options have to be discussed.
Is it something that you can dictate your bariatric surgery colleague which surgery he or she should do?
So we discuss with the patient, like whether when the patient has morbid obesity, we take a call, because patient discussion is very important. A Roux-en-Y is a major surgery. So we have to do the discussion with the patient and with the bariatric surgeon, and then take a call. Like if the patient has morbid obesity, severe obesity, more than 40 or more than 35, then, and with high risk comorbid conditions, then we take a call on that.
Right. Suresh, you wanted to say something?
No, I just want to add upon maybe I think the super obesity area. I work with the bariatric team, but the super obesity areas, there is no doubt about it. They should go for a bariatric procedure. But even the mild and moderate ones, I refer mainly with the comorbidities, people with a terrible sleep apneas, arthritis, and bad diabetes, and I think is on multiple drug regime, and their quality of life is affected. Those kind of people will get more benefit. But Dr. Subhankar Chowdhury's question is whether can you control our surgeons, whether they can do this thing. Probably not. It is like having an adenocarcinoma or a thyroid lump or something. We cannot control our surgeons.
Fine, thanks. So
we still try to have a discussion with the board. Like we have a sort of a group, and where we discuss, and we discuss with the patient also, because sleeve versus Roux-en-Y, we have to discuss the post-op things also.
So that's the ideal thing to do. You have the surgeon on board as well. Yeah, that's great. So finally, we'll wind up with Dr. Riaz's question or comment, that something maybe that I've already mentioned. Therefore, for those who have got diabetes, maybe small frequent meal platter is more applicable, and for non-diabetic obese, maybe intermittent fasting may have a bigger role.
provided
So yes,
provided that normal person going into intermittent fasting should follow it. The compliance is there.
yes, absolutely. Compliance is always a big issue. So with these few words, I would like to thank each one of you this evening who joined in, and I hope we could get our points across to a wide range of physicians across the country. Usually, I get a number. I'm trying to see how many joined. I can't see it today, but usually it's upwards of 1,000 physicians who join, and I'm sure they'll be able to implement this in their clinical practice as well. Thank you very much. Have a very good evening, all of
Thank
you.
you, sir. Thank you. Thanks,
Bye-bye,
everybody.
Tris.
And thanks for our
Bye.
audience and for those excellent questions that they have put. Thank you very much.